This program is brought to you by Emory University.
Good morning. Happy Friday, everybody. Welcome to Fellows Conference. We have a journal club today, two presenters. Our first up is a second-year clinical fellow, Dr. Ryan Cousins, did his residency here at Emory, and he's going to talk to us about, looks like Lp(a). So take it away, Ryan.
All right, thank you, Dr. Williams. Good morning, everybody. For those that haven't had the pleasure of meeting yet, I'm Ryan Cousins, like Dr. Williams mentioned, one of the second-year fellows here at Emory. We're going to be presenting on the topic of little a, big impact, lipoprotein A and major adverse cardiovascular events in patients with and without atherosclerotic cardiovascular disease. No financial disclosures or conflicts of interest to present today. So we'll start with the clinical vignette. So say you have a 45-year-old male. He's got a history of hypertension, hyperlipidemia, type 2 diabetes, non-insulin dependent, family history of coronary artery disease. He presents to your preventive outpatient cardiology clinic as a new patient visit. He has no known history of ASCVD, and you decided to obtain a baseline lipoprotein A level, and it shows that he's got a value of 125 nanomoles per liter. So a few questions I want you to consider as we go through this presentation are, how would you counsel this patient with regards to his risk of MACE, given this value? If his value came back more elevated at 225 nanomoles per liter, 225, how would you kind of guide his MACE moving forward? And what if he actually had known coronary disease or ASCVD? How would that sort of change your management and recommendations for him? The central questions or objectives for this talk today are, what is the association between lipoprotein A and MACE? And for this presentation, the definition of MACE was non-fatal myocardial infarction, non-fatal stroke, coronary revascularization, or cardiovascular mortality among patients that do and do not have baseline ASCVD. In addition to that, could the optimal lipoprotein A thresholds for risk stratification actually differ based upon this different threshold of baseline ASCVD? And with regards to that, which populations of patients would then be most affected by elevated levels of lipoprotein a, and would therefore potentially benefit the most from the novel targeted therapeutic interventions that are down the pipeline here? A little bit of background. So lipoprotein A, it's a low-density lipoprotein variant. It's grown in significant interest over the past 30 years. As described in one of the commentaries for this article, it's almost like an LDL particle on steroids. So you can see to the right, you have that LDL lipid-rich core with apolipoprotein B surrounding it. And some of these particles are attached with this apolipoprotein A with a disulfide bond with variable numbers of copies attached to that. And we know that this is associated with increased risk of incident MI, ischemic stroke, and calcific aortic valve disease over the lifetime of the individual. In general, guidelines for what is the highest threshold or threshold to consider highest risk vary. But in general, from some guidelines, so any levels greater than 125 nanomoles per liter correspond to the 80th percentile in population-based studies that have been used in US guidelines to identify those that are higher risk. But there have been different assays that have existed throughout the past 10, 20, 30 years for measuring these different levels. And so that kind of creates a little bit of a challenge for comparison studies such as this one. Briefly looking at the ACC-AHA expert analysis guidelines in terms of which patients might be reasonable to go ahead and try and get a baseline lipoprotein A level on, essentially boils down to, with primary prevention on the left, secondary prevention on your right, whether the patient or their family has premature, or their for primary, if their patient's family has premature ASCVD, significant severe hypercholesterolemia, we're considering that are concerned for FH, or if you're trying to sort of risk stratify these patients based upon their ASCVD risk, well, if they have an elevated lipoprotein A level, does that sort of lend you towards more wanting to initiate or have discussions about starting a statin medication? And then for secondary prevention, again, personal or family history of premature ASCVD. If you're not able to reduce your LDL levels or lipid lowering goals, despite being on a pretty decent regimen, you may want to consider if this is a risk factor playing a role as well. So these are just some of the general guidelines to consider. Until recently, lipoprotein A has been considered an unmodifiable cardiovascular risk factor within its 30-year course. However, there is the advent of small interfering RNAs antisense oligonucleotides. So the landscape of these novel therapeutics is actually showing some promise in terms of reducing this lipoprotein A levels. And for those that are interested, the two phase 3 clinical trials currently in place right now are Horizon and Ocean A. In addition, there's research to suggest that PCSK9 inhibitors have actually been observed to also decrease circulating lipoprotein A levels by as much as even 20%. And the patients who benefited the most from PCSK9 therapy in terms of cardiovascular benefit and events were those that had significantly elevated LDL-C and lipoprotein A levels as well. And the two trials that demonstrated that for further reference as well are the Fourier and Odyssey trials. That brings us to our article for today, and this was published in JACC about a few weeks ago by Dr. Berman et al. And the title of the research project was Lipoprotein A in Major Adverse Cardiovascular Events in Patients with or Without Baseline Atherosclerotic Cardiovascular Disease. So briefly, this is a retrospective cohort study of patients that had a lipoprotein A level that was measured anywhere during their routine care at two medical centers in Boston, at Mass Gen and the Brigham, over about a 20-year span, nearly from January 2000 to July 2019. And given the different lipoprotein A level assays that were developed and used throughout the time course here, the trial group decided to actually break everything down to percentile groups rather than specific numbers with different reference values that I'll show in the next few slides here to assess the relationship between lipoprotein A and MACE. Class proportional hazards modeling ratios were used to assess these associations between lipoprotein A and MACE. And overall, there were about 21,410 patients that were considered to be eligible for the study. And then based upon the breakdown, which I'll go through in the next slide shortly here in terms of inclusion and exclusion criteria, 16,000, roughly 16,000 made the cut. And there was actually a pretty decent median follow-up of roughly 12 years for this data collection. So speaking of the inclusion and exclusion criteria for patient selection, not too much for inclusion criteria. The patients had to be greater than 18 years of age and had at least one lipoprotein A result with screening for the cohort inclusion. Now, in terms of the exclusion criteria, these are criteria that make sense in terms of excluding patients for this study. However, the article didn't necessarily dive too deeply into why they considered these as exclusion criteria. But basically, if the patient had severe kidney dysfunction, stage 5 CKD, or an EGFR less than 15, history of kidney transplant, if they were on dialysis during the covariate assessment period. And essentially, the covariate assessment period was if this lipoprotein A level was obtained 12 months before the level was obtained or 30 days after the level was obtained. In addition, if they had a malignant neoplasm during that study window, excluding non-melanoma skin cancers, and basically, there's a typo here, I apologize. Individuals who died during the covariate assessment window as well were excluded. Very briefly, this is a supplemental appendix that basically just demonstrates the relationship between the different mass assay and particle assays that were used to measure these levels and the different percentile groups on the left that these study designers ended up breaking everything down with regards to which values corresponded to what percentile groups. Again, as we briefly mentioned, the endpoints were essentially composite of MACE that included non-fatal MI, ischemic non-hemorrhagic stroke, coronary vascularization, or cardiovascular mortality. This brings us to Table 1, which is the baseline characteristics of everyone within the study. You see the risk factors on the left side of the column and the numbers for everybody with regards to all patients, those broken down by ASCVD versus no ASCVD in the middle columns and the p-values on the right. In this study, about 2/3 of the patients ended up having ASCVD, 1/3 did not have ASCVD. And most of the ASCVD risk factors for these patients were about 80% of the ASCVD group had a previous myocardial infarction, with 70% having coronary vascularization. But a lot of the different cardiovascular disease risk factors, including stroke, AFib, heart failure, as you can see the p-values on the right, compared to the non-ASCVD group, were all statistically significant in terms of the difference there. In terms of demographics, so the ASCVD group had about a 10-year median age range higher than the no ASCVD group in terms of 64 to 54. This study was about 2/3, roughly a little more than 2/3 or less than 2/3 rather, directed in terms of more males versus females. And then with most studies still coming out in this day, about 80%, give or take, were predominantly white for the patient cohorts. More baseline characteristics, so the laboratory values of the cholesterol panels that were broken down on the left, in addition to the medical therapy that the patients were currently on. I want to specifically highlight that the median LDL for the ASCVD group and no ASCVD group of 90 and 109 coming into this respectively, we're still above the desired goal ranges for these patients, which we'll kind of get to and touch upon a little bit later on in the course of the presentation. But the median lipoprotein A level was about 37 for the ASCVD group and 31 for the no ASCVD group. In addition, for those that had ASCVD, only about 75% of these patients were actually still on statin therapy. Briefly, table 2 just kind of breaks everything down with regards to lipoprotein A distribution, stratified by ASCVD risk in terms of those numbers there. And then this is more of a bar graph that demonstrates the percentile groups and the different lipoprotein A levels that they broke down in terms of these percentiles. So the first to 50th was 0 to 41 nanomoles per liter, 51st to 70th, 42 to 111, 71st to 90th was 112 to 215, and 91st to 100th was anything greater than 216. This kind of brings us to the meat of the results of this presentation. So figure 2 goes through the association between lipoprotein A percentile groups with that primary composite endpoint of MACE. So you'll see in terms of the graph and tables here, you've got cumulative incidence of MACE on the left and the follow-up year period on the x-axis, and the adjusted hazard ratio for those with ASCVD with the 4 different percentile groups represented by the 4 different colors here, with the 1st to 50th percentile group with that blue line on the bottom, essentially demonstrated that as time went on, based upon your percentile groups, you did have a subsequent stepwise increase in rate of those cumulative incidents. However, you can see the lines between the 71st and 90th percentile group and the 91st to 100th percentile group actually were fairly similar even out to the course of about 12 to 15 years in terms of their MACE cumulative incidence percentage. Now, a similar table that goes for the no ASCVD group actually shows a little bit of a different trend with regards to those percentiles. As you can see, there still is a sequential increase in terms of the percentile group and your risk of cumulative incidence of MACE. However, there is a vast difference with regards to a stepwise increase between the 71st to 90th percentile and the 91st to 100th percentile in terms of that purple line that seems to kind of extrapolate even higher than those bottom percentile groups there. And so this is a bit of a busy table, but essentially this breaks this down to the composite endpoint of MACE, again, with and without ASCVD in terms of the exact numbers for each group in terms of the top table. But the bottom table essentially goes through the adjusted hazard ratio using the 1st to 50th percentile as your reference point for each group. And I highlighted this in the red boxes here. So as you can see, the adjusted hazard ratio, for the ASCVD group, as mentioned, did sort of increase as you kind of went higher in terms of your percentile groups. But the 71st to 90th percentile and 91st to 100th percentile, we're fairly close to each other in terms of the ASCVD group. But moving over to the farther bottom right column of this table, you can see that hazard ratio jumped significantly from 1.17 in the 71st to 90th percentile group to almost 1.93 in the 91st to 100th percentile group. This essentially is another supplemental table that I'll briefly spend some time on that essentially demonstrates that the unadjusted and adjusted hazard ratios for the table that I previously just showed, that was based upon the trial designer's own breakdown of their different percentile groups. And they decided to go ahead and break that data down into what was more of a generally acceptable clinical lipoprotein A cut points and cohorts on the left-hand side, with less than 75%, less than 75 nanomoles per liter, 76 to 125, 126 to 175, and greater than 176. And that essentially demonstrated the same trend that we saw from the previous tables here. This is one of the more interesting figures in the article itself as well. So basically, this is another association between the annual event rates of that primary composite outcome between those that had ASCVD and those that did not. Starting with the left, this is the one with ASCVD, as we kind of briefly keep reiterating. So again, that percentile group in terms of the 71st and onward almost exactly the same in terms of their annual event rates of 5.3% each. And then moving over to the right in B, you can see that massive stepwise increase once you get to the highest percentile for those with no ASCVD. Interestingly enough, in terms of the annual event rate percentage, those that had 91st or 100th percentile but no ASCVD still had a twofold risk less compared to those that had known ASCVD in even the first to 50th percentile from 2.2% to 4.1%. So the presence of ASCVD in terms of analyzing this lipoprotein A level and what this all means clearly has a significant role to play in terms of annual event rates, which makes sense. Briefly flying through, so that was the composite endpoint, and we were breaking it down by each of those 4 different variables. So this is the percentile groups in myocardial infarction. And basically the short summary of this is that the myocardial infarction for ASCVD and non-ASCVD does follow the same exact trend as the composite endpoint. It may in fact even been the one that sort of drove all that information there too as well. Between the ASCVD group you can see here, where the log rank P was still significant, and then no ASCVD as well, with a very similar trend and similar p-value there too. In terms of the other supplemental figures, so this breaks it down to the second variable in terms of coronary revascularization, and this follows the same trend as the myocardial infarction pool, with again, both log ranks being significant in terms of both groups. However, this trend does not continue when you break it down to non-fatal ischemic stroke, that for the ASCVD group didn't necessarily show a difference in terms of trend, but this did still show significance with no ASCVD. And the non-fatal ischemic stroke also had the similar trend when you come down to cardiovascular mortality, with again, the ASCVD group not having a statistically significant difference there, or at least approaching it. But the no ASCVD group was still significant with regards to that trend. Finally, the last figure demonstrates a really cool restricted cubic spline modeling, which essentially shows with the red lines here in terms of the ASCVD groups on the left and the no ASCVD groups on the right. If you're using the 50 nanomoles per liter as kind of your reference point in terms of your hazard ratios, you see this interesting kind of increase, but almost plateau effect for those that had ASCVD as you get to about the 150 to 200 nanomoles per liter. However, in terms of the no ASCVD group, the higher that lipoprotein A level goes, the higher that hazard ratio goes as well. So there's more of a little bit of a linear relationship there, whereas it plateaus a bit more for ASCVD. Finally, that brings us to the central illustration, kind of briefly summarizing everything we just briefly discussed. You've got your cartoon model of the lipoprotein A molecule on the left, your cardiovascular events, the 4 of them that we included in the study in the middle, and that breaks it down again to the left of those that have no ASCVD and the right with those that prior ASCVD. And you can see that trend, that linear relationship between the no ASCVD in terms of lipoprotein A level and hazard ratios, but the plateau effect again for those that had prior ASCVD. So in conclusion, the authors of the article mentioned that among individuals with a history of prior ASCVD, there is a meaningful increase in incident ASCVD, MACE, particularly for MI and coronary vascularization, but not for ischemic stroke or cardiovascular death, with increasing lipoprotein A levels. And this higher risk was predominantly observed once you got to the 71st percentile and above. And this is a threshold that is currently lower than is used in the current trials, as I mentioned previously, that are undergoing investigation for lipoprotein A lowering therapies, or when we should be initiating or using lipoprotein A as a risk-enhancing feature. In addition, in terms of the bottom bullet point, among individuals without a history of ASCVD, there was a higher lipoprotein A threshold for identifying those at elevated risk for MACE, specifically greater than the 91st percentile, and higher risk was observed overall for all 4 individual components of that composite endpoint. A couple more conclusions. Among those with baseline ASCVD, individuals with lipoprotein A levels greater than the 70th percentile then may benefit most from the additional aggressive risk factor modification, and again, possibly in the future, these lipoprotein A lowering therapies. And again, in those without ASCVD at baseline, those greater than the 90th percentile seem to be the highest attributable risk from elevated lipoprotein A. So why do we think there was this leveling off with regards to the ASCVD group at the higher percentiles? Well, some ideas and suggestions that the authors recommended was that potentially, for these patients, once we get to highest ASCVD levels, these are patients who hopefully are caught to be known as the higher risk individuals and hopefully are aggressively treated in terms of preventative therapies, including maybe antiplatelet therapies. So, and in addition, once you kind of reach a certain threshold with ASCVD in terms of lipoprotein A, then this may be just less potent. You've already maybe reached a saturation threshold with regards to future ASCVD risk. So that was kind of the explanation in terms of the plateau effect there. In addition, so for those patients that didn't have prior ASCVD, as we mentioned, they're about 10 years younger, had significantly fewer risk factors for ASCVD. Well, once we get that lipoprotein A level, is there something else that we could use to also kind of risk stratify these patients a little bit more with regards to whether we need to put these patients on statin therapy or not, say if they fall into that like 71st to 90th percentile range, give or take. So maybe the addition the authors mentioned of including coronary artery calcium scores for these patients could also guide those that may need to be more aggressively treated earlier on. Several limitations of this study. So just by nature, it was retrospective, which also lends towards the validity being not quite as much as a randomized controlled trial. As mentioned earlier, there were a large number of different and evolving lipoprotein A assays that were used across the board over the nearly 20-year study period there as well. And again, the median LDL starting points for these patients in terms of both groups are also above goal. And so in addition to that, with the next bullet point there were suboptimal rates of use of statins. So only 75% of those in the ASCVD group were on statins. So the combination of both of these variables were to suggest, well, if we, for most of these patients, if we had been able to be maybe a little bit more aggressive in terms of their LDL goals at baseline and putting them on whatever statin therapy that they could tolerate, maybe that would kind of lend towards a different conclusion with regards to lipoprotein A levels and MACE events. Finally, so the lipoprotein A measurements were performed as part of just routine care during this course of study and were not necessarily always part of a regimented guideline-directed fashion with regards to who should get the test and who should not. And finally, these findings were, of course, from a large academic studies center, so they may not necessarily be generalizable to all ethnic minorities and patient populations or other practice settings as well. Briefly, finally, some of the future directions. So it'd be really interesting to sort of substratify these subsets of patients in terms of their patient characteristics and risk factors, because we do have studies to suggest that, lipoprotein A levels or even LDL cholesterol and other risk factors levels are different with regards to different patient populations. So kind of more finer tuning in terms of what these recommendations may mean based upon these variables would be interesting to consider. And in addition, with these lipoprotein A therapies that are coming out in the near future, it would be interesting to see sort of how, once these therapies hit the market and patients are on them, how do we adjust these thresholds with regards to who should be on these medications and what goals do we have in place what are we trying to get to with regards to lowering lipoprotein A levels in terms of future events with MACE as well. I'd like to formally, sincerely thank Dr. Izzy Adenso for her help and suggestions and looking through everything with regards to my slide set and providing some amazing recommendations and references to look at as well for this presentation. These are my subset of references. I appreciate your time today and welcome any questions.
Thank you, Ryan. I guess my question is, I think I have with the low risk people, I think Lp(a) is a good, potential indicator of sort of hidden increased risk, if you will, for as you mentioned, and I think that's been pretty well established. I guess what I'm trying to understand is for your higher risk individuals or individuals with prior events, if they do end up in this greater than 90% category that puts them at increased greater risk than they otherwise would be. Let's say a patient, is already on 80 milligrams of atorvastatin and their LDL is at goal, but they still have a, quite high Lp(a). I guess, how would you apply that? Like, what would you, is that like, they're already on quite intense therapy and seemingly a goal with their LDL goals. Like, what would you recommend? Or what, for that group of patients?
Yeah, it's an excellent question. I think we're still trying to figure out exactly, sort of where those patients fall with regards to their eventual MACE. I guess from what the study has suggested that ideally, if yes, say they have, these risk factors, they're already on high intensity statin therapy, they're at their goal, but they're maybe in that 90th or 100 percentile in terms of lipoprotein A, and everything else across the board is essentially either well controlled or not necessarily an ASCVD risk factor. I think then that at the very minimum, at least from what the data shows, suggests that we, need to have a significantly thorough conversation with the patient with regards to, that they still are at an increased risk in terms of MACE in the future. And then, there isn't necessarily, at least at this point, until the novel therapeutics are coming out, to suggest and say, hey, really, atorvastatin's been the only statin that has shown to potentially lower these LDL, maybe some PCSK9 we saw, maybe you consider putting
additional
them.
LDL lowering, it's like
Sorry.
we have the discussion about additional LDL lowering therapies, like PCSK9 or adding ezetimibe or bempedoic acid or whatever.
Yeah, maybe you consider a PCSK9 inhibitor in terms of considering to still lower them, but even though they're at goal, I guess, if they're at that LDL goal, I think we still don't know necessarily, again, what lipoprotein A level to potentially drop these patients to in terms of reducing their risk. So it's still kind of hard to guide, like you said, what to do for these patients with regards to additional LDL lowering therapies or lipoprotein A lowering therapies at this moment. I think it's just all you can say is that there's still an elevated risk for MACE, but I don't think necessarily continuing to even lower the LDL beyond current goal guidelines. I'm not sure if we have data to suggest that that reduces their risks of MACE or not.
Other questions from the group?
Yeah, I have a comment regarding this whole area of LP little a. So, Brian, you and I may have discussed this previously, but one of the conundrums for me about this whole area is that the most potent lowering agent for LP little a is niacin. Niacin has a huge LP little a lowering effect, yet it has no effect on MACE. And so when we do all these studies on LP little, so clearly the agents that lower LP little a selectively are going to be critical to understanding whether this is just a marker or something else, or in fact is causative in the development of atherosclerosis and the subsequent development of complications of atherosclerosis. So to me, all of this remains largely pie in the sky until we have some data that addresses this issue.
All right. Well, thank you, Ryan. Thanks, Dr. Thames, for your input. And Ryan, you can stop sharing your screen. Our next speaker is Matthew T. Brown, third-year fellow in the clinical track, former Emory resident. And he is going to talk to us today, as you can see, about implantable hemodynamic monitors in heart failure patients. Take it away.
All right. Thank you, Dr. Williams. Good morning, everyone. This is an interest of mine, as I'm interested in remote monitoring and kind of the opportunities for telecardiology. I'm pursuing an advanced heart failure fellowship, and I was excited to see this February 2024 JACC meta-analysis looking at 3 different trials over the years of implantable hemodynamic monitors with results that suggest improvement in survival in patients with heart failure and reduced ejection fraction. All right, so throughout the talk, I wanted to start with a review of implantable hemodynamic monitors because I was surprised to see how long they've been around. And then we'll evaluate the results of this recent meta-analysis and consider the impact on heart failure management. All right, so starting, I like this graphic as it depicts all the different opportunities and locations for implantable hemodynamic monitors to be inserted and to gather data. And I've arranged this in terms of a little bit of a timeline, as the first hemodynamic monitor implantable was actually a right ventricular pressure sensor. and it was very similar to a pacemaker ICD device. It was called the Chronicle, and its first in-human trial pilot was done in 2003. So over 2 decades ago at this point. More recent devices are located in the pulmonary artery, usually in the distal pulmonary artery. And I think everyone may have heard of CardioMEMS. The first in-human trial was in 2011 for this device. And there is another option called the Cordella that has become available, or not available on market, but is in human trials. This provides a little bit more data. Next up are left atrial pressure monitors. These devices, mainly the heart pod, which has been around since 2010, actually connect with the interatrial septum and directly monitor the left atrial pressure. There's also a device that's has some ongoing clinical trials and is newer, called the VLAP, which almost looks like an Amplatz occluder, and it fits in the interatrial septum. And then finally, we have a device called FIRE1 that sits down in the IVC. I thought this was a nice array of the available, or not so much available, but possible potential locations for these hemodynamic monitoring devices. Now, this study mainly focuses on some of the earlier data, as they wanted to include long-term follow-up. So the Cordella, the VLAP, FIRE1, these all have some ongoing clinical trials, and we'll focus on the former 3. So I wanted to start with the Chronicle device. As you can see here, it looks very similar to a pacemaker and ICD. It's compatible with each of those right ventricular single chamber devices, and it measures RV pressure. It has this little harpoon-like device, and it can measure RV systolic pressure, diastolic pressure, and then it estimates the end diastolic pulmonary pressure as well. Early data for it did not show anything significant for heart failure hospitalization reduction or mortality, but there weren't as many events as they had anticipated to really project those things. But when they boiled it down and looked at time to first hospitalization, they did see a slight significance there. And that kind of was the jumping off point for these next couple devices that we have more data on. So this is the CardioMEMS device. It's a very small device, and it is placed via femoral access into the right femoral vein usually. It's inserted via right heart catheterization, and there is a selective angiogram that is performed to see exactly where the best place to release it is in the distal pulmonary artery. It just fully expands there, and it takes up about 10% of the lumen. It does endothelialize over time, so it requires at least dual antiplatelet therapy, if not anticoagulation if the patient's already on it. And it's compatible with MRIs, compatible with pacemakers, ICDs, and it is actually a device that you don't have to charge. It charges externally from the patient monitoring device, or the patient monitoring system. It is currently the only approved implantable hemodynamic monitor on the market, and we'll go through some of the data that led to that. Now, the next one is a device that you probably haven't heard of. It's called the Heart Pod, not having anything to do with Apple or iPods. This is another device that looks similar to a pacemaker ICD. It's got a subcutaneous generator that actually charges externally as well. So it's lifelong, it has lifelong durability, and it's connected to a lead that actually implants in the interatrial septum. So the implant procedure involves a transseptal puncture, and the operator has to strategically place this in the interatrial septum. A patient goes home with a little monitoring device, and that device actually helps kind of guide them on what to do with their diuretics. Now, you'll see that You've probably never heard of this device because it had some safety issues in the early trials, and that was stopped short. We'll explore that in a little bit. Putting all this together, I like this chart to kind of look at the evolution and what has been tried and what has resulted of it really over the past 20 years. And of course, keep in mind, there's more in the pipeline, but we've explored RV pressure monitoring, pulmonary artery pressure monitoring, and then direct left atrial pressure monitors. And the meta-analysis that we're going to go through now really focuses on the CardioMEMS device and then the HeartPod device. And each of these in their own separate trials have shown efficacy in reducing heart failure hospitalizations. So we'll go through that now. As I said, over the past 2 decades, there have been many trials that have looked at these type of devices, and the more recent ones have been able to show heart failure hospitalization reduction. However, none have been able to show any benefit in mortality. So the authors for this meta-analysis wanted to focus on the population of patients that they felt would have the highest cardiovascular mortality, as other studies had combined heart failure with reduced ejection fraction and preserved ejection fraction. So they wanted to focus solely on the heart failure reduced ejection fraction, as rates of cardiovascular mortality are higher in that group. They also wanted to expand follow-up. So they were able to do a survival analysis at 24 months. And then they picked these studies in particular because they were able to get patient-level data, which was not available for, say, for instance, the Monitor HF study. And that is why that one was left out. So the 3 trials that they picked were Champion, which was kind of the breakthrough landmark trial for CardioMEMS, Guide HF, which was our CardioMEMS trial that was impacted by the COVID-19 pandemic, and then Laptop HF, which was this HeartPod left atrial pressure trial. And we'll see what they came up with. But for each of these trials, the criteria, of course, just some definitions here. Systolic heart failure was defined as ejection fraction is less than or equal to 40%. And then heart failure hospitalizations were unplanned hospital admissions due to volume overload requiring IV diuretics. It wasn't going to the urgent care, it was actual hospital admission. In order for patients to be enrolled in these studies, they needed to be stable and optimally titrated on guideline-directed medical therapy. We'll see some of the numbers and adherence to that. And then they were randomized. Now, this is where things get a little interesting. They were randomized to implantable hemodynamic monitors and the standard of care versus just standard of care. And then you'll see in 2 of the studies that the control group actually had the device implanted, whereas the 3rd study did not implant and just left patients with standard of care. So let's explore these 3 studies. I thought the article actually gave a nice graphic about each one. And you see that Guide HF, Champion are both our CardioMEMS studies. All 3 were prospective, multi-center, randomized controlled studies, but Guide HF and Champion are single-blinded, meaning that both the treatment group and the control group underwent device implantation and then had the same sort of frequency of follow-up and interventions. Now, the Laptop HF study did not implant in the control group. That's an important distinction to make as we move forward. All right. Additionally, it's important to take into account the times that these studies were conducted. As you see, Guide HF was our most recent and of course affected by COVID. Champion and Laptop were earlier in the 2000s, where some of that guideline-directed medical therapy like ARNIs and SGLT2s were not regularly used. The duration of follow-up for Champion and Laptop was longer than that in Guide HF. And the primary endpoints were a bit different, as well as the inclusion criteria, with both Champion and Laptop focusing solely on NYHA Class 3, but Guide HF expanding that. All right. And it's important also to take into account sample size. While Guide HF started off with the largest amount of patients at baseline, and this is subsets of the greater studies, looking solely at the heart failure reduced ejection fraction group. You'll see that Guide HF, it drops off by 12 months and then 24 months, and that is greatly affected by COVID. They cite this, and if we were to delve into that specific area of concern, they took some time and analyzed, not in this study, but this article was cited that was published in 2022 about what exactly happened and what about the COVID pandemic may have led to kind of a change in the early looks at what was going on with Guide HF, which, if the pre-COVID analysis showed a hazard ratio for heart failure reduction events that was statistically significant, barely, but it seemed to be right on that threshold. And once COVID started, they cited an event reduction in the control group by 21%. That basically negated this statistical significance. And they looked into, did COVID affected, were medication changes any different, were people not being contacted? And it wasn't the case. They actually saw PA pressures were reduced in both groups, and people continued to upload. So they chalked it up to more patient behavior changes, which is an interesting analysis itself. And then going back to this slide, looking at comparing the studies, it's also very important to say, the safety outcomes for Laptop led to a stop in the implant at around 363 patients because there were higher rates of device-related complications or procedure-related complications. And this is in the supplemental figure. You can tell that 46 subjects, 20% of the patients that underwent heart pod implant and had some sort of issue. That's why the trial wasn't continued. But a substantial amount of patients did get randomized, and it's that group that they were able to generate this data from. So getting into the details of this patient level data and looking at the demographics, what we see is mostly a middle-aged white male with New York Heart Association Class 3 symptoms. There is 25% female enrollment and 25% Black enrollment. Looking at medical history and baseline characteristics, we see similar rates of about 50% of patients had ischemic etiology to their heart failure. The BMIs were similar, around 30, 31, 32. And then ejection fraction was severely reduced, 25% in average. Diastolic pressures for Guide HF and Champion were around 19, as were they for the left atrial pressures in the Laptop HF style. And then finally, this is probably the area of biggest differences. Laptop HF didn't include much biomarker data, and then also had an unusually low rate of ICD use. In terms of GDMT, beta blockers were the highest GDMT across the board at about 95%, and then diuretics are almost even higher, 95% plus. Of course, SGLT2s weren't around, really hadn't been included in the guidelines, and the ARNIs were just being introduced, more so in the Guide HF. You can see the uptick there. So I thought the authors did a nice job of compiling this data and kind of keeping it separate and then moving on to the compilation. They showed that looking specifically at the subsets with reduced ejection fraction, in each one of these studies that there is a reproducible, statistically significant reduction in heart failure hospitalizations on the order of, here, 19%, no, excuse me, 29%, with guide HF. And this is, of course, the pre-COVID population for that study. With Champion, which was a bit larger study, the significance was even greater at 31%. And then Laptop HF actually was the most significant of all of them, but of course stopped early. Now, when they compiled these results, they received a curve that looked like this. You can see separation starting pretty early on at 1 month from implant, that reach a total significance of 36% reduction in heart failure hospitalizations at 1 year. So I thought it was impressive. Now, looking at mortality data, I wanted to have each one of these charts kind of available to look at, because I think it's apparent some of the limitations, as guide HF was cut at about 1 year, and actually had started to show some inverse with the treatment effect, whereas the control group seemed to be doing a little bit better. Looking at Champion, that wasn't the case for it. The treatment group seemed to have some better survival. And then Laptop, which was not statistically significant or just on the border. Laptop HF was the one study that actually did show some significance here, as they brought it out to 2 years of follow-up. So compiled with these 3 studies, they were able to show a 25% reduction in mortality at 2 years. And really, if you look at the curves, that it doesn't start until after a year. So they speculated that it takes time for the decongestion process to translate to a mortality benefit. Now, looking at this data in kind of a different graphical form, I like this forest plot because it kind of shows how things are a bit weighted. Again, shows kind of a reproducible reduction in heart failure hospitalizations, but overall, the reduction in death is significant. It favors treatment, but guide HF was on the other side, and then it seems like Laptop HF kind of pulled the analysis in favor of treatment. Now, one other thing that was in the supplementals that I thought was really impressive was looking at the change from baseline, either PA end diastolic pressure or left atrial pressure over the gamut of the 12 months. It was impressive to me to see that while there was some significance in reduction between the treatment and control groups, it wasn't all that impressive. It was just maybe 1 millimeter of mercury. And I thought I was honestly expecting a bit more of a reduction that either in diastolic pressure or left atrial pressure to be able to translate to these clinical outcomes. So I did enjoy this editorial comment that came after the article, and it was written by Murat Budim, Javed Butler, and Dr. Lipoprotein. But they kind of gave an overall perspective, or drew some insight, and made delivered some thoughts on where implantable hemodynamic monitors kind of fit in to the really armamentarium of devices for heart failure. They looked at other devices in this chart and showed, CRTs, showing their FDA approval and then where they fit in with the guidelines. Obviously, these implantable hemodynamic monitors are simply diagnostic devices, whereas some of these are can be therapeutic, or largely therapeutic. But CRTs, ICDs, LVADs, MitraClip, they likened some of the trials that have shown, either reductions in mortality or heart failure hospitalizations, um, and kind of correlated that with studies that have been done for these implantable hemodynamic monitors, and started with the chronicle RV pressure monitor early on that didn't show any significant improvement in heart failure hospitalizations or mortality, but looked at kind of the compiled analysis that they performed in this meta-analysis and said, maybe there's a new place, or maybe we should consider an update to the guidelines and where these devices fit in. I think this is subject to interpretation. I did like the author's conclusions. I thought they came up with a nice kind of hypothesis for what exactly was going on, as people were able to be monitored more closely and remain decongested for longer. Some of the physiologic changes and the benefits of being able to see these data over time to maintain lower intracardiac pressures and up-titrate GDMT in a more dramatic fashion, and then keep patients decongested for longer. Overall, I think that this data shows a significant reproducible reduction in heart failure hospitalizations. I think the mortality benefit is seen only after 12 months and was largely aided by this laptop heart failure study inclusion. That brings up the limitations. These are two separate devices. If we're comparing pulmonary artery pressures to left atrial pressures, it's not exactly apples to apples. And then especially in the laptop group, you had this opportunity for the Hawthorne effect where, some patients were implanted, others were not. So that some people knew that they were being monitored continuously. Other people, and the data was totally up to them transmitting what their weight and blood pressure was. I think that kind of introduces some bias as well. And then all three of these studies really largely predated our modern 4-pillar guideline directed medical therapy. So overall, I think there is a role for implantable hemodynamic monitors, but it warrants careful patient selection. And I think those that may benefit the most are those with reduced heart failure. Yes, I liked how this was focused on that. But at the same time, having recurrent hospitalizations, I think those people benefit the most, may benefit the most. That's where I see this kind of fitting in to my idea of heart failure, especially reduced ejection fraction management. But these are some references, and I just want to give a special thanks to Dr. Abdu, and then and Dr. Merchant, who would discuss some of the chronicle device during my EP rotation, and then our VA faculty who heard the early version of this talk and gave me some much needed feedback. So I welcome any questions, and thank you so much for tuning in and listening.
Thank you, Matthew. Dr. Smith has his hand up.
Yeah, Matthew, I just have some editorial comments, really. The other forms of outpatient monitoring, such as daily weights and those types of things, to date, there has not been a randomized trial that's shown benefit. In the ESCAPE trial that was done years ago, where patients were randomized to get swans to manage heart failure, the thing that was most predictive of a favorable outcome was if the wedge pressure was below 18 at the time that the catheter was taken out. And that was much more predictive than cardiac output above or below 2. So a low left atrial pressure, low wedge pressure tends to portend a good prognosis. And all of these hemodynamic trials where they have shown that whether it be the estimated pulmonary diastolic pressure in chronicle or the PA pressure with the CardioMEMS, if you can keep that wedge below 20, that patients generally do not get rehospitalized. And it's symptoms that drive hospitalizations, and symptoms can be driven by high wedge pressures. So the the concept of how do you lower wedge pressure. Now, also in the ESCAPE trial, on the things that were most predictive of a high wedge pressure were the elevated neck veins and the presence of orthopnea. And orthopnea is a symptom that we do not pay as much attention to as we should in educating our patients about what they need to do. I was on the steering committee for both the Chronicle trial and the CardioMEMS trial. The problem with the initial Chronicle was that the patient enrollment, we enrolled patients who were too ill. So like you said, these devices don't do anything directly, they just monitor. And so you have to have an intervention as an outpatient that's going to work. And that intervention is generally to increase diuretics. And if patients are not diuretic responsive, then you're not going to show benefit. So what was shown in Chronicle was, yeah, you mentioned something about the initial hospitalization time to was decreased, but overall hospitalizations were not decreased. And that's because there were patients who were admitted 5 and 6 times who required inotropes, and they skewed the results. So then we got into a second phase of Chronicle, and that was looking much more favorable. But what happened was the device itself did not work after about 3 or 4 years. So Medtronic, they stopped pursuing that. The laptop with the left atrial pressure monitor, the problem there was that there were too many complications in crossing the septum and having operators who may not have been used to doing that. So the things that matter with this are, does the monitoring system actually work? Can it be done safely? Will it work long time? Will patients use it, which is an issue with CardioMEMS. We have some patients who don't transmit, so that's not helpful. Are the patients responsive to a treatment? And on the treatment side, will the team actually intervene? So if you're seeing high pressures and you're not doing anything, then that's not helpful. One of the advantages of the hemodynamic monitors is that they also allow us to decrease diuretics when we see pressures getting too low. So those were just some issues. You know, I think one of the things that the device companies are trying to do is use other forms of hemodynamic or of physiologic monitoring, and I think people should be aware of HeartLogic technology that Boston Scientific is working on. That unfortunately the randomized trial on that is not going to be done in the United States. But those are just some comments. It's low wedge helps long term. You need a device that actually works and is safe to input. You need to select patients. If you select ones that are too well, you're not going to show benefit. If you select patients that do not show a response to treatment, you're not going to show benefit. And so that's sort of where this situation fits in. I think some of the patients that we found that might be most helpful are patients where you have trouble determining their physical status, and with obese patients, we have found that it can be quite helpful in those patients.
Dr. Laskar has his hand up.
Yeah, just to editorialize along with Dr. Smith, I think there is, particularly for the CardioMEMS device, which from the clinical trial and from registry data has been shown to be safe to implant and pretty safe long term. I mean, the biggest barrier for implant in these devices from a referral standpoint is that many commercial carriers do not adequately reimburse for the device. Medicare does. Based on the clinical data, if you have a stage, I say this provocatively on rounds sometimes we talk about CardioMEMS, but based on the clinical data, if you have a stage C patient who's got a reasonable renal function and is not stage D and will follow your instructions, there's practically no huge barrier or reason not to think about a CardioMEMS device. The practical reason is the implant approval and things like that, because it is safe to implant. Even a heart failure cardiologist can put it in, and it is something that has been shown not just in clinical trials but in the registry data, using patients as their own controls to decrease rehospitalization. So if it was easier, and not easier to implant, but if it was just easier to get through the approval process, there would be more patients with these devices. I think we follow about, Dr. Abdu, if he's on, will know, I think we follow at least 60 patients, 60 to 70 patients with the CardioMEMS device. And there are some issues with making sure that you can follow patients appropriately and things like that, and intervene appropriately, and have a system in place for that. But there's not there are practical barriers to this therapy, but not necessarily there's an argument to have more widespread use for this type of monitoring device.
Yeah, thanks both Dr. Laskar and Dr. Smith and Matt. Good overview. Agree with both Dr. Smith and Laskar's comments. They summarized what I was about to say better than I would have done. And yeah, we here at Emory, we follow around 65 patients or so. And if it hopefully more to come. It's just like the barriers that were mentioned before me. I mean, the limitations logistically from a payer standpoint and reimbursement and things like that. But however, anecdotally, I can tell you on top of since I'm the one who implants them and kind of quote unquote supervises the MEMS program. I'll tell you anecdotally on top of clinical trial data and registry data that the device has positive impact on patients. A lot of these patients who we implanted them were frequent flyers to the hospital. I mean, every 3-4 weeks they're in the hospital. We have not seen them since we implanted the device. Of course, this all comes down to patient selection as well. And the notation of lowering your diuretics when you need to lower it and preserve kidney function and prevent orthostatic hypotension, so on and so forth, is important too. A lot of times we think that 100 milligrams of torsemide daily will be effective, but once you decongest these patients, they don't require that much, and you can monitor them with a objective pressure data. So there is room for this device for sure. I would love to see more patients on them, especially those stage C heart failure patients who are willing to kind of be adherent and respond and all that. I think that will have a very positive impact on their quality of life and reduce their hospitalizations for sure, and therefore reduce their mortality.
All right. Well, thank you, everyone. Thank you to Matthew for his presentation. Thanks to Dr. Smith and Laskar and Abdu for their comments. And thanks everybody for tuning in. And we'll see everybody next week.
The preceding program is copyrighted by Emory University.